In 1932, a 70-year-old man climbed onto an operating table, looked up at the ceiling of his own hospital, and told his nurses to hand him a scalpel. He was not the patient that day. He was the surgeon. Except he was also the patient. He had been awake for 4 hours already, prepping, studying the notes from his previous surgeries, the ones he had also performed on himself. His hands were steady. His breathing was calm. The nurses had seen this before. This was Dr. Evan O'Neill Kane, and this was the 6th time he was going to cut himself open. Nobody stopped him. That is the part of this story that gets overlooked. The man did not sneak into an operating room in the middle of the night. He did not act in secret or in desperation. He walked in as the chief surgeon of a hospital he had helped build, sat down in his own chair, and operated on his own body while fully conscious, fully alert, and completely certain of what he was doing. His colleagues stood by because they had no argument left. He had already proven his point. He had proven it 5 times before. But the 6th surgery was different. The 6th surgery was the one that would follow him into every medical textbook that came after. To understand why a man would do this, you have to go back to a time when going under the knife meant something much more terrifying than it does today. You have to understand what anesthesia looked like in the late 1800s, and why so many patients who survived their surgery did not survive what the doctors gave them to sleep through it. Evan O'Neill Kane was born in 1861 in Kane, Pennsylvania, a town that was literally named after his family. His father was a Civil War general, a man who built railroads and helped carve a city out of nothing in the mountains of western Pennsylvania. Growing up in a town that bore your last name does something to a person. It either fills them with expectation, or it fills them with a need to do something worthy of it. For Evan, it was both. He went into medicine the way some men go into a fight, with complete and total commitment. He graduated from Jefferson Medical College in 1884 and returned to Kane to practice. The hospital there was small, under-resourced, and surrounded by the kind of industrial labor that produced a steady stream of serious injuries. Miners, loggers, mill workers. Men who came in with broken bones and crush injuries and infections that had been ignored too long. Kane operated constantly. He got very good, very fast. But there was something that bothered him throughout those early years, something he watched happen again and again and could not stop thinking about. Patients would survive his surgery. He would do everything right. The wound would close, the bleeding would stop, the repair would hold. And then, hours or days later, the patient would die. Not from what he had fixed, from the ether. General anesthesia in that era was administered with cloth soaked in ether or chloroform held over a patient's face. It was crude, imprecise, and genuinely dangerous. The dose could not be controlled with any real accuracy. A patient who was too fragile, too elderly, or simply unlucky could go under too deep and never come back. Cardiac arrest was not a rare outcome. Aspiration, where a patient inhaled their own vomit while unconscious, killed people regularly. Respiratory failure, hypoxia. The list was long and the numbers were real. Kane kept a private count. He never published it at the time, but those close to him said he tracked every patient he lost to anesthesia complications the same way another man might track a debt he owed. He was not loud about it. He was methodical. And by the time he was in his 40s, he had a theory he could not let go of. Local anesthesia existed. It had been around since the 1880s, when cocaine was first used as a topical numbing agent in eye surgery. By the early 1900s, Procaine, which would later be marketed as Novocaine, had been developed and was being used for minor procedures like dental work and small skin surgeries. The idea was simple. Instead of putting the entire body to sleep, you numbed only the area that needed to be cut. The patient stayed conscious. The heart kept beating at its natural rhythm. The lungs kept working without assistance. The recovery was faster, and the risk of death dropped significantly. The problem was that the surgical community did not believe local anesthesia could work for major operations. Abdominal surgery, chest surgery, anything that required going deep into the body. The consensus was that local anesthesia was not viable. Patients would feel too much. They would panic. The muscle tension from a conscious patient would make the surgery technically impossible. The pain would be unbearable. These were not fringe opinions. These were the mainstream conclusions of the most respected surgeons alive. Kane disagreed, and he spent years trying to make his case through the normal channels. Papers, presentations, arguments with colleagues at conferences. The response was polite dismissal. He had no proof. He had theories, and he had logic, and he had a growing file of anesthesia-related deaths that made him furious. But he had no proof. So he decided to get some. The first time Kane operated on himself, he was removing a growth from his own finger. This was around 1910, and it was, in the scope of what he would later do, genuinely minor. A small benign tumor. Local anesthesia, a clean cut, a few stitches. He performed it in front of witnesses. He wanted people to see that a surgeon could remain calm, could maintain fine motor control, could think clearly and execute precisely while wide awake and watching a blade move through his own tissue. It worked. His hand was steady. The procedure was clean. He sutured himself, wrapped the finger, and went back to work the same afternoon. He later removed a growth from another finger. Then he worked on his own eye, removing a small cyst from the area around it. Each time he brought colleagues in to watch. Each time he documented everything. The dosage of the local anesthetic, the duration, the level of sensation, his own heart rate, his observations about pain and discomfort and clarity of thought. He was building a case study, and the subject of that case study was himself. But fingers and eye tissue were not enough. Anyone could argue those were surface-level procedures that proved nothing about what local anesthesia could do for real surgery. Kane knew this. He had always known this. The only way to settle the argument was to do something that could not be dismissed. Something deep. Something that required going into a body cavity. Something that every surgeon in the country would recognize as real, serious, undeniable work. He had been thinking about the appendix. The appendix sits in the lower right quadrant of the abdomen. Removing it requires cutting through layers of tissue, working in a space that is not large, and maintaining awareness of surrounding structures that cannot be accidentally nicked. It is not the most complex surgery in medicine, but it is absolutely not minor. People died from appendectomies in the early 1900s, sometimes from the operation itself, and sometimes from the anesthesia required to perform it. It was exactly the kind of surgery that the critics said local anesthesia could never handle. Kane chose February 15, 1921. He was 59 years old. He had been planning this for months, possibly years. He had consulted with colleagues, not to ask permission, but to make sure his anatomy notes were precise and his plan was sound. He arranged for assistants in the operating room. Nurses who would hand him instruments and a physician who could take over if something went wrong. He wrote detailed notes beforehand about what he intended to do and why. On the morning of the surgery, he walked into the operating room at Kane Summit Hospital, the institution he had spent decades building, and he lay down on the table he had stood beside for thousands of operations. The local anesthetic was administered to his lower abdomen. He waited for it to take effect. He tested the sensation with a light probe. Then he nodded and asked for the scalpel. What happened next was witnessed by everyone in that room and reported in newspapers across the country within days. Kane made the incision himself. He worked slowly and carefully, pausing when he needed to reposition, talking to the nurses as he went, describing what he was feeling and what he was seeing. At one point, his intestines began to protrude through the incision, which is a normal occurrence in abdominal surgery, but requires the patient to remain still. Kane remained still. He asked for a retractor and continued. He found the appendix, separated it from the surrounding tissue, ligated the blood vessels, and removed it. He handed it to the nurse beside him. Then he sutured himself closed, layer by layer, and waited to be helped off the table. The surgery took approximately 30 minutes. Kane was awake for all of it. The recovery room was quiet when the reporters arrived. Kane was sitting up, not lying down. He had asked for coffee. A nurse brought it, and he held the cup himself, steady. The same hands that had just removed his own organ now wrapped around white ceramic, like nothing unusual had occurred. The reporters wanted drama. They wanted a man broken by pain or trembling from what he had done. What they found was a surgeon reviewing his own surgical notes and pointing out what he thought he could have done faster. The news spread fast. Headlines across America described it the same way. A surgeon removed his own appendix while awake. The story was astonishing on its surface. A stunt, a spectacle, the kind of thing that gets attention because it sounds impossible. But Kane did not want attention. He wanted a response from the medical establishment, because what he had done was not a stunt. It was a controlled experiment with one specific conclusion. Major abdominal surgery under local anesthesia was survivable, functional, and in many ways preferable to general anesthesia for patients who could tolerate it. The medical community could not ignore it this time. He had done the one thing they said could not be done, and he had done it on himself, in front of witnesses, with documentation, at 59 years old. The argument was not over, but the ground had shifted. Journals that had previously rejected his ideas began requesting papers. Surgeons who had dismissed him at conferences began writing letters. The appendectomy had not changed every mind, but it had changed the conversation. Kane spent the next several years doing what he had always done, operating. Not on himself, on the hundreds of patients who came through Kane's Summit Hospital every year. But now he was applying the lessons from his own body. He used local anesthesia more aggressively in his practice, in cases where other surgeons would have defaulted to ether or chloroform. He tracked outcomes. He kept meticulous records. The data he was accumulating pointed in one direction. Patients who underwent surgery with local anesthesia and remained conscious had lower complication rates and faster recoveries than patients placed under general anesthesia for comparable procedures. This was not a theory anymore. It was a pattern. But he was also aging. By the late 1920s, Kane was approaching 70. His hands were still steady. His mind was still sharp. His colleagues would later describe him as someone who seemed to have simply decided that age was not going to slow him down. A decision that was not denial, but something closer to will. He continued operating. He continued publishing. He continued arguing his case. And then his own body gave him another problem. Kane developed a hernia, an inguinal hernia to be precise, which is a protrusion of tissue through a weak point in the abdominal wall near the groin. They are common, uncomfortable, and if left untreated, they can become dangerous. The standard treatment was surgery, and the surgery required, under the protocols of the day, general anesthesia. Kane looked at this diagnosis the way he had looked at every other physical problem his body had produced over the past 2 decades, not as a misfortune, as an opportunity. He was 70 years old. If he could demonstrate that a 70-year-old patient, which was considered elderly in 1932, could undergo hernia repair surgery under local anesthesia and recover without complication, he would be making an argument that no one in medicine could dismiss. Because the elderly were exactly the population most at risk from general anesthesia. The heart, the lungs, the kidneys, all of the systems that general anesthesia placed under stress, they were also the systems most likely to be fragile in an older patient. Every year, elderly patients died not from what the surgeon did to them, but from what the anesthesiologist gave them. Kane had watched this happen his entire career. If he could show that the alternative worked even at 70, the implications for elderly surgical patients across the country would be enormous. He told no one outside of his immediate surgical team what he was planning, not because he was hiding it, but because he already knew what the response would be, and he was not interested in arguments. He had heard all the arguments. He had outlived most of the people who had made them. On February 4th, 1932, at Kane Summit Hospital, Evan O'Neill Kane prepared for his 6th self-surgery. The preparation was thorough. He reviewed his own anatomy notes from decades of hernia repairs performed on other patients. He discussed the procedure with his assisting physician, going through each step in sequence, making sure there was a clear plan for what would happen if something went wrong. He was 70 years old, and he was not reckless. He was precise. There is a difference, and Kane understood it better than almost anyone alive. The local anesthetic was administered. Kane positioned himself on the table, adjusted the lighting, tested the sensation in the surgical area. Then he made the incision. The inguinal hernia repair is a more technically demanding procedure than an appendectomy in certain respects. The anatomy in that region is dense and intricate, with nerves and blood vessels running close together, and the repair itself requires careful work with mesh or suture to reinforce the weakened tissue so the hernia does not recur. Kane had done hundreds of these operations. He knew the anatomy the way a pianist knows a piece they have played for 30 years, not by thinking about it, but by feel. He worked through the procedure calmly. The nurses in the room would later describe him as quiet, focused, occasionally asking for an instrument, occasionally pausing to rest a moment, never showing signs of panic or distress. The local anesthetic held. The pain was manageable. Kane made his repair, confirmed it was sound, and began closing. He was nearly finished when something changed. Somewhere in the final stages of the closure, Kane developed a complication. The surgical notes from that day are not fully preserved. But what is known from the accounts of those who were present is that there was a moment when Kane paused, assessed what was happening in his own body, made a decision, and continued. He did not call for general anesthesia. He did not ask to be taken off the table. He finished what he had started. When the surgery was complete, Kane was moved to recovery. He was, by all accounts, exhausted in a way that the previous surgeries had not left him. He was 70 years old, and he had just spent a significant amount of time doing precise surgical work while lying on his back with an open wound in his own abdomen. The recovery was slower than it had been in 1921. His body needed time. He had time, and he used it the way he always had, reading, writing, corresponding with colleagues, reviewing cases. He did not treat the recovery as a period of diminishment. He treated it as a period of documentation. The paper he eventually published on the hernia surgery, combined with the accumulated data from his years of practice, made a specific and measurable case for the expanded use of local anesthesia in surgical patients over 65. He cited his own case as one data point among many, not as the centerpiece of the argument, but as the most visible example of a principle that his patient records supported independently. The self-surgery was the headline. The 30 years of data behind it was the proof. Within a decade of that final surgery, the conversation around anesthesia in American hospitals had shifted in ways that Kane had spent his entire career pushing for. Spinal anesthesia, regional nerve blocks, and local infiltration techniques began appearing in surgical training programs not as curiosities or edge cases, but as legitimate primary options for appropriate patients. The elderly and the medically fragile. Exactly the population Kane had always been most concerned about, began receiving more targeted anesthesia approaches that reduced their exposure to systemic agents. Kane did not live to see the full arc of that change. He died on April 1, 1932, less than 2 months after his 6th surgery, at the age of 70. The official cause of death was pneumonia, likely related to complications from the procedure and the demands it had placed on an aging body. He had known the risk. He had operated anyway. There is a version of this story that frames Kane as reckless, a man so convinced of his own theory that he used his own body as a laboratory over and over until it finally caught up with him. That version is not entirely wrong. The decisions Kane made were not without danger, and the final surgery almost certainly shortened his life. But there is another version. A version where a doctor watches patient after patient survive their disease and die from their treatment. Spends decades trying to change it through the proper channels, gets politely ignored, and finally decides that the only argument left is the one no one can dismiss. His own body, his own hands, his own documented outcomes. A version where a 70-year-old man gets on a table one last time, not because he has anything left to prove to himself, but because he believes that what happens in that operating room, if it goes the way he knows it will, might keep someone else's grandmother or grandfather alive when they need surgery, and cannot survive what the anesthesiologist plans to give them. Every elderly patient who has undergone surgery with regional or local anesthesia, rather than general anesthesia. Every person whose surgeon offered them a conscious sedation option and explained why it was safer for their particular body. Every advance in anesthesia practice that prioritizes preserving the patient's own physiological function rather than overriding it. Those advances exist on a continuum that runs through Kane Summit Hospital in Western Pennsylvania, through an operating room in 1921, and again in 1932, where a surgeon lay down on his own table and picked up his own scalpel. The nurses said his hands were steady both times. That is not a small thing. That is the whole thing. What medicine remembers about Evan O'Neill Kane is usually reduced to the headline: surgeon removes own appendix. It gets filed alongside other medical curiosities, strange footnotes in the history of a profession that has seen its share of unusual characters. But the footnote version leaves out the part that actually mattered to him. It leaves out the patients he lost before he understood the problem. It leaves out the decades of documentation. It leaves out the last surgery, the one he did at 70, not for his reputation, not for the newspapers, but because the argument was not finished, and his body was the only instrument he trusted enough to finish it with.